Welcome to all participants. Today's webinar is funded by Echosens North America, the inventors, manufacturers, and marketers of the FibroScan technology. This webinar includes information on the uses of the FibroScan technology in the published literature. Echosens does not intend to make any specific claims in this presentation. The FibroScan device is FDA cleared as a tool to the aid in the management of liver disease and is not intended for the treatment of any specific liver disease or condition. I'm now pleased to introduce our featured speaker, Dr. Doug Dieterich of Mount Sinai Medical Center in New York City. Many of you know Dr. Dieterich from his extensive publications and speaking engagements in the industry. He is the director of the Institute of Liver Medicine at Mount Sinai and the co-author of the recently published AGA Elastography Guidelines, which is the topic of today's webinar. Dr. Dieterich is a graduate of Yale University and received his doctorate in medicine from New York University School of Medicine. His GI fellowship was completed at Bellevue Medical Center. Beyond his clinical duties at Mount Sinai, he's a clinical professor of medicine at New York University. And with that, I would like to turn it over to Dr. Dieterich.
Thanks, Jerry. Happy to be here. I think we saw these, you heard these slides already. So we're going to talk about the role of elastography and primarily based on the AGA elastography guidelines now. So we have some solid guidance on exactly how we can use this in the best and most effective way. We want to thank the Joe Lim and Andy Muir, who's part of the team that put together these guidelines for most of these slides. So the methodologists, as you can see here, the AGA guideline committee chair, Siddharth Singh, who was the statistician, basically. Andy and I were the technical reviewers, and Steve Flam and Joe Lim were on the guideline panel, Joe being the chair. So the development process is here. We don't have to go through this, actually, but to say it was extremely complex and thorough, involving a whole bunch of different literature reviews and Pico questions. These are the references here published in Gastro this year. Two different ones: a guideline publication and a technical review. And in case you want to know what is a Pico question, Pico is a technique used in evidence-based medicine to frame and/or answer a clinical or health-related question. So P stands for patient, problem, or population, depending on the situation. I is the intervention. C is comparison, control, or comparator. And then O is the outcome that we expect or desire. So these are the Pico questions for viral hepatitis. For hepatitis C, it was the role of VCTE, which is vibration-controlled transient elastography, versus APRI or FIB4 for the diagnosis of cirrhosis, the VCTE cutoff for the diagnosis of cirrhosis, the cutoff for the exclusion of advanced liver disease after SVR, and the role of MR elastography versus VCTE for the diagnosis of cirrhosis. For hepatitis B, it was the role of VCTE versus APRI-FIB4 for the diagnosis of cirrhosis and the cutoff for the diagnosis of cirrhosis. For NASH and ASH, the role of VCTE, the same questions basically for APRI-FIB4 and MRE versus VCTE for the diagnosis of cirrhosis. Alcoholic liver disease was basically just looking for the cutoff for the diagnosis of cirrhosis. And actually, this is I think probably a clinically important one. The cutoff for exclusion of high-risk esophageal varices, and then portal hypertension preoperative assessment, exclusion of clinically significant portal hypertension. So you know when to do endoscopy for ruling out varices. So for hepatitis C, this was the question, the role of VCTE versus APRI or FIB4 for the diagnosis of cirrhosis. So should this be used to diagnose cirrhosis in adults with chronic hepatitis C? All of these guidelines are for adults, by the way. Or should VCTE versus FIB4 be used to diagnose cirrhosis in adults? So here's a recommendation. It's relatively simple. There was a lot of data here, so as you'll notice as we go along, the earlier questions have the most data, and as we get towards the back of the slide deck, the data becomes thinner and thinner, and the recommendations will become less firm. So in patients with chronic hepatitis C, the AGA recommends VCTE if available, rather than APRI or FIB4 to detect cirrhosis. This is a strong recommendation with moderate quality evidence. So this was obtained from 36 studies of VCTE, 24 with APRI and 2 with FIB4. And the sensitivity and specificity were significantly superior, 0.89 and 0.91 compared with the APRI and FIB4. We did not look at the serum assays because, as you probably know, most of those are kind of all over the place and usually read really high. This is my bold down here. So when you're making any kind of clinical decision about this, reliance on any one fibrosis assessment tool, you have to use all of the information available to you. So if the VCTE reads out a low number, but the platelets are 49,000, maybe you should sort of rethink this or redo it or take a look at the rest of it. If the VCTE reads a high number and the platelets are 250,000 and the patient looks totally healthy, you should also sort of take everything into consideration. So this doesn't wipe away your clinical judgment. You still have to look at the patient and all of the numbers and information, excuse me, available to us when we make these diagnoses. So at what liver stiffness cutoff can we accurately diagnose cirrhosis? What's the number? And initiate downstream management, obviating the need for a liver biopsy. These questions, by the way, weren't really made for PowerPoint. They're made for the science. Anyway, the recommendation here is chronic hepatitis C. The AGA suggests a cutoff of 12.5 kilopascals to detect cirrhosis. This is a conditional recommendation with low quality evidence. Although, if you look at the numbers here, the pooled effect estimates came from 17 studies with almost 6,000 patients. And the sensitivity was 0.86 and the specificity was 0.91, which may misclassify less than 5% of cirrhotic patients as non-cirrhotic and less than 10% of non-cirrhotic patients as cirrhotic. So once again, the bold here, caution in using this cutoff should be considered in the context of other clinical information. So if it's less than 12.5 and the patient has spiders and gynecomastia and other signs of cirrhosis, then obviously you should keep that in mind when you're making your clinical decisions about how to take care of this patient. Okay, so here are the numbers. The hepatitis C disease, the cirrhosis cutoff is 12.5 kilopascals, 0.86% sensitivity, 0.91 specificity, positive and negative predictive values here. I think mostly we were worried about the negative predictive values, and those are actually quite high, 99 and 94%. We guesstimated in the beginning that we could tolerate a false negative rate of 5 to 10%. And that's exactly, we're well within that range here in the negative predictive value range. Now, what about the cutoff for exclusion of advanced liver disease after SVR? In adults with Hep C who have achieved an SVR, at what liver stiffness can we accurately rule out advanced fibrosis and consider discharging patients from a dedicated liver clinic? Now, important point here, this is a pre-treatment elastography measurement, not post-treatment. We'll mention that in a second, actually. So here's a recommendation. In non-cirrhotic patients with Hep C who have achieved SVR, the AGA suggests a post-treatment vibration-controlled transient elastography cutoff of 9.5 kilopascals to rule out advanced liver fibrosis. This is a conditional recommendation with low-quality evidence. The comment here is non-cirrhotic patients with less than 9.5 who place a low value on the inconvenience and risks of continued laboratory and fibrosis testing and a high value on avoiding the small risk of developing HCC may reasonably select to continue specialty care rather than being discharged from the specialty clinic. And that's obviously a patient and physician preference, so you all can use your judgment there. Now, you can see the two bolded bullets here. There's an evidence gap. Additional research is needed to further define the role of single or serial elastography testing, as well as the appropriate liver stiffness threshold in the management post-SVR. So, so my note here is this is a really important point, and I don't think any one of us knows the answer to this one yet. So this is a pre-treatment measurement. So if someone comes in your office on the first or second visit, you get this number. No one on the committee was willing to make a recommendation if the patient came in with a 12.5, and then after treatment, in a year or so, dropped down to 5 or 6 on the kilopascals, which is considered to be totally normal. Should we or can we stop screening for HCC? No one was actually able to make that recommendation, and all of us would continue to screen for HCC if they ever had a reading above 12.5 or 9.5, actually. Until we know, actually, and it's going to be a long time before we have enough longitudinal data, I think, to be able to figure that out. Okay, so here's the advanced fibrosis guidelines. The number is 9.5, and the negative predictive values, 99 and 90, here well within the 5 and 10% maximal tolerable range here. So 9.5 cutoff stage 3 disease for lifelong Hcc screening. So here's an example of a case. So a 56-year-old male with hypertension and depression, typical baby boomer, presents for a newly diagnosed chronic Hep C infection, believed to be acquired from distant IV drug use 25 years ago. He reports no current alcohol consumption. His exam shows no overt signs of cirrhosis except for possible palmar erythema. I'm not so sure how reliable a sign that is for sure. His labs show white count of 5.6, hematocrit of 46, platelets 151, creatinine and billy are all normal, alk phos 82, AST and ALT slightly elevated at 78 and 65. He's genotype 1A and HCV RNA is 2.63 million. So you wish to determine if he has cirrhosis to guide your treatment approach. So which of the following statements is true, now that you're all experts in this, regarding the role of VCTE for assessment of liver cirrhosis in this patient? Excuse me. So VCTE should be performed within 30 to 60 minutes following oral intake of a meal with 20 grams of fat to facilitate detection of cirrhosis. VCTE is recommended if available over other non-invasive serum tests such as APRI and FIB4. A VCTE liver stiffness cutoff of 19.5 is recommended for the detection of cirrhosis. And all patients who have achieved an SVR following completion of antiviral therapy may use a post-treatment VCTE score of 9.5 to exclude cirrhosis and obviate the need for HCC surveillance. That's kind of a big word for PowerPoint too, obviate. Second time we've used it here. Okay, so here's the answer. I hope you all voted. VCTE is recommended over APRI and FIB4. So let's look at the answer, at the wrong answer. A is should be performed within 30 of 60 minutes following an oral meal. No, that's completely untrue. That's the cheeseburger test. Okay, if you wanted to raise the FibroScan score up to the stage 3 or 4 range, that's how you would do it, because you'd get a bump in the score of 3 or 4 points after a big fatty meal in particular. Honestly, we ask our patients to be fasting for at least 2 or 3 hours before we do the test, because a large meal increases portal blood flow to the liver, which actually increases liver stiffness. VCTE liver stiffness cutoff of 19.5 is recommended for the detection of portal hypertension. We'll talk about that in a minute. So it's not, and actually cirrhosis is actually 12.5. And then all patients who have achieved an SVR following completion of antiviral therapy may use a VCTE score of 9.5. Remember, it's a pre-treatment VCTE score of 9.5, not post, because we don't really know what to do with these folks yet. We're still trying to figure that out. Although most of us, or almost everybody I've spoken to, is actually continuing to screen for HCC. So it's commonly used. There are a lot of them now across the US. It does have some technical and diagnostic limitations. Increased, error, higher numbers in people who have just eaten, in acute hepatitis, people with high liver enzymes, alcohol abuse, congestive heart failure, and extrahepatic cholestasis, all of which would actually increase liver stiffness. So the AGA suggests that a diagnosis of cirrhosis should begin at 12.5 level, 12.5 kilopascals. Among non-cirrhotic patients who are less than 9.5 who achieve an SVR, after careful consideration, you may actually tell them that they don't need lifelong Hcc screening, but of course that's up to you and the patient. That's not a super strong recommendation. And of course, Hcc surveillance should be considered with anybody who has a higher number than 9.5 or 9.5 or higher before therapy, not after. Okay, hepatitis B. The evidence here starts to thin out a little bit as we get further along in the deck. So can you use it to diagnose cirrhosis in adults with chronic hepatitis B? And the recommendation is, in patients with chronic hepatitis B, the AGA suggests VCTE rather than other non-proprietary, non-invasive serum tests, that is APRI and FIB4. And this is a conditional recommendation with low quality evidence. Although there were 19 studies for VCTE here, 5 for APRI and 4 for FIB4, that's a pretty good number. The sensitivity was 0.86 and the specificity 0.85. Also really, really good numbers. The serum assays were not looked at here. And once again, we suggest caution in reliance on any one fibrosis assessment tool. The patient obviously looks cirrhotic or the other way around, then you should use your clinical judgment and look at all the factors that are responsible for making the diagnosis of cirrhosis. What liver cutoff can we accurately use to diagnose cirrhosis and avoiding a liver biopsy? not many people with Hep B would get a liver biopsy nowadays anyway. In patients with chronic hepatitis B, the AGA suggests a cutoff of about 11. So it's lower to detect cirrhosis. This is a conditional recommendation with low quality evidence, although it comes from 17 studies evaluating almost 5,000 patients. But the sensitivity and specificities 0.81 and 0.83 were slightly lower. And this is obviously always the same caution here, considered in the context of other clinical information. So look at the whole package, the platelet count, the symptoms, and any other imaging results that you might have. So here are the numbers here for hepatitis B. The cirrhosis cutoff is 11. The negative predictive values, though, are actually quite good at 99 and 91. So very useful tool, not to be relied on totally for the diagnosis of cirrhosis. Now, how about fatty liver disease? This is where things get much more controversial. Should we use it versus APRI or FIB4 to diagnose cirrhosis in patients with non-alcoholic fatty liver disease? This would be a huge benefit, particularly in the clinical trials world now, if we could use this to diagnose cirrhosis or fibrosis scores, because the number of liver biopsies in many of the fatty liver trials nowadays is excessive and makes it very difficult to accrue these trials. So this was a technical review by population, setting an estimated prevalence of cirrhosis in NAFLD patients in one practice. So if we look at a high-risk population, that 30% might have cirrhosis, the risk factors being advanced age, obesity, central adiposity, diabetes, and ALT over 2 times the upper limit of normal. And then the low-risk population, where we might find cirrhosis in about 5% of the population. So this is a difficult slide to read, so I think we're just going to move right on. And it's a little bit easier here to see. Okay, so if we look at this, this chart here, VCTE, there were 9 studies. The cutoff was for cirrhosis was between 10.3 and 22.3. The sensitivity about 0.9 and a specificity of 0.87. So actually, that's actually not bad. Much better than those scores for the APRI and the FIB4. Quality of the evidence, though, is kind of low. And the pooled estimates felt to be subject to unacceptable bias in this group, because we only looked at the M probe, so very obese patients were excluded. Obviously, if they couldn't get a measurement, those patients were excluded, and this is a per protocol rather than intention to diagnose analysis. If you failed to succeed in getting the FibroScan, the patient was not included in these papers here. So that's why it's a low grade evidence. What about cirrhosis? Actually, there's significant imprecision here. So there's no recommendation in terms of cirrhosis. Liver biopsy still remains the gold standard here to diagnose non-alcoholic steatohepatitis in particular, because I don't think there's really any way to determine the difference between NAFLD and NASH unless unless you do a liver biopsy. So I think we may still be in the biopsy mode for this particular diagnosis for a while. Also, this study did not look at the at the CAP probe, by the way, the fat content in the liver, which clinically we find quite useful, but it was not FDA approved when we started this exercise in 2015, so we didn't include it in the guidelines. So here's the alternative NAFLD cutoff value reference that you can use, which was published by Nid Afdal's group in Current Gastroenterology in 2014. So significant fibrosis was more than 10, and they called cirrhosis at 14. And then there's other liver diseases here are pictured. Hep B at 12, Hep C at 12, co-infection at 14, and cholestatic liver disease at 17, and NAFLD or NASH at 14 for cirrhosis. So, I mean, these are within a very small range, actually, when you consider the range of the entire spectrum of disease from 5 to 75 kilopascals. So in adults with suspected compensated cirrhosis undergoing VCTE, at what liver stiffness cutoff can we accurately rule out high-risk esophageal varices, obviating the need for routine endoscopic screening? I think this is very valuable, actually, and it's valuable information. And really, you know, there's a whole difference between cirrhosis with a kilopascal cutoff of 12.5 and cirrhosis with a capital C, in that when your kilopascals range way high up in the range, way above 20, you know, to 30, 40, and 50, it's a whole different brand of cirrhosis. These patients are much, much sicker. So this number was determined to be 19.5 kilopascals to predict portal hypertension and variceal screening. So this is a pooled estimate from 8 studies with almost 1,000 patients. So the sensitivity was pretty good here, 0.89, specificity not so good. But 19.5, you could round it off to 20, seems to be the cutoff value. Anything at that level or higher should have endoscopic screening for varices. So in a high-risk population, say 20% varices, compensated cirrhosis, platelet count less than 150, no overt features of portal hypertension. You know, it was looked at there. And in the low-risk population, only 5% risk of varices, platelet count over 150,000, no overt features of portal hypertension. So here's the true positives, false negatives. Let's skip this one. This is actually a little too complicated with all these numbers here. But if we go right to the main issue, the false negatives, this is the ones we don't like to miss. And the low risk prevalence, incorrectly classified as not having varices, only about 6%. And the high risk prevalence, 20%, it was about 20% actually. So false negatives. That's the dangerous issue here, the non-prediction. So the recommendation, actually in patients with suspected compensated cirrhosis, AGA suggests a vibration-controlled transient elastography cutoff of 19.5 to assess the need for endoscopy to rule out high-risk esophageal varices. This is a conditional recommendation with low-quality evidence. So obviously use your clinical judgment here. There's significant heterogeneity observed in the test characteristics. So if the CT or MRI shows very significant portal hypertension, but the number on the VCTE is less than 19, I think you probably should use your judgment and do the endoscopy anyway. Okay, so here are the other guidelines. Here, ASLD 2017 suggests that a liver stiffness of less than 20 and platelet count of more than 150,000 have a low probability, less than 5%, of having high-risk varices, and you don't have to do the endoscopy. If you don't meet these criteria, then screening endoscopy for the diagnosis of gastroesophageal varices is recommended. Bovino 6 Patients also, they suggested a liver stiffness value of less than 20, and with a platelet count of more than 150,000 have a very low risk. And these patients can be followed up yearly by transient elastography and platelet count. No need to do liver biopsies. And if the liver stiffness increases or the platelet count decreases, these patients should then undergo screening endoscopy. Now, what about NAFLD? Even though this would be incredibly useful for NAFLD, can we use MR elastography versus VCTE to diagnose cirrhosis? Here are the numbers. MR elastography, about 84% sensitive, 89% specific, 83% sensitive for VCTE, but much less specific. It was 0.72. This was only based on 2 studies, however, comparing MRE and VCTE in NAFLD patients. Once again, we'll skip over these numbers tables. They're hard to decipher on a slide. So the way we looked at this was a high-risk population and a low-risk population. 30% cirrhosis, false positives, 119 out of 1,000 fewer with MR elastography. Low-risk population, both of them performed poorly. False positives compared to true positives, MRE was 2.5 times higher and VCTE was 6 times higher. And there's also concern for downstream consequences and greater harm than benefit. So in adults with NAFLD and a higher risk of cirrhosis, the AGA suggests using MRE rather than VCTE for the detection of cirrhosis. That this is a conditional recommendation with low quality evidence. In patients with NAFLD and a lower risk of cirrhosis, the AGA makes no recommendation regarding this. There's no recommendation knowledge gap here. Now, high risk populations with NAFLD, with diabetes, advanced age, obesity, central adiposity, AST, ALT, more than twice the upper limit of normal, with an estimated cirrhosis prevalence of 30%. This is versus the low risk population, less than 5%. So that's actually all the time we have for the slides. I think that's a pretty exhaustive review of how we use FibroScan in the real world, and some very, very well-supported evidence-based guidelines on what numbers we should be thinking about for cirrhosis, Hcc screening, and other things when it comes to the use of VCTE in clinical practice. So can we open up the mics to questions, or how do you want to do this? Type them in?
Yes, thank you, Dr. Dieterich. This is Jerry Mayberry. For the questions and answers, I want to introduce Sunil Hasmain of the EchoSense North America team. Sunil manages all of our non-invasive diagnostics and their usage in clinical trials. And Sunil has been monitoring the questions coming in through the chat fields, and he will read the questions one at a time, and Dr. Dieterich can respond with them. As a reminder to everyone that is online, if you'll go to the questions field, you can type in any question that you want, and Sunil will manage posing those. So Sunil, can you state the first question, please?
Sure, thank you. And by the way, I just wanted to preface by saying that, it's natural that there'll be a lot of questions that come in, and we'll try to answer them thematically. If we, for whatever reason, don't get a chance to answer your question, please email Jerry, who just sent this email, and we can follow up with you. So the first question, Dr. Dieterich, is something I think you touched upon, but it's a very important topic, so it's been asked again. how would you manage HCC risk in an HCV patient that had a pre-treatment liver stiffness of say 14, and then post-SVR has come down to 10?
Well, I mean, either number actually really means HCC screening for life, which is what we tell the patients actually. So, you know, they say, when can we stop seeing you? And I say, never. You're going to have to keep coming in, and you know, the recommendations are screening twice a year. So we have them come in twice a year. Typically, depending on their risk factors, you know, we'll do ultrasound alternating with MRI screening. Or if we, for instance, if we do see a bump in the AFP, then we'll switch to just MRI screening.
Thank you. And then there was another question here. Is VCTE recommended prior to HCV treatment rather than ultrasound? And I'm presuming that to mean standard ultrasound.
Not in place of, it's actually recommended along with. Ultrasound can't really diagnose fibrosis. And actually but that's a really important point. So VCTE is used to measure liver stiffness. So it gives you a fibrosis score like liver biopsies used to, you know, stage 1, 2, 3, or 4, you know, on the Medivir scale, whereas abdominal ultrasound screens for liver cancer. So I think, you know, some of the patients, when we tell them to go do an ultrasound, they don't understand that the FibroScan was not their ultrasound, so they don't go. So you have to sort of make a big effort to make that clear to them that these are two different synergistic ultrasound type machines. The FibroScan will evaluate the fibrosis, and the ultrasound will screen for liver cancer or portal hypertension.
Thank you. And there was a number of different serum markers you had mentioned. For example, the APRI, FIB4, etc., all slightly different. Is there a clinical rationale to use one over another?
To use APRI over FIB4? No, not really. I mean, FIB4 doesn't have INR involved in it, so it's a little easier from your usual existing clinical data. So that's actually, you know, a lot of people do that. But as you can see, the sensitivity and specificity of those were around 75% compared to the VCTE numbers in the 90s. So, you know, I think they're much less accurate. And I think the other FibroSpec and, you know, FibroSure are also much less accurate as well.
All right. This question is, it's interesting. It's related to the material that was touched upon, but slightly different because throughout the presentation, the etiology was sort of well defined as we went through the presentation. This question is, this practice gets a lot of referrals for patients suspected of having cirrhosis or portal hypertension, but the etiology is unknown. Is there still a role for FibroScan in giving a suspected diagnosis or suspected interpretation for those patients who may have elevated stiffness?
Yeah, I mean, I think absolutely. The if you remember that one of the last slides we presented with the, you know, from the Afdal paper, all the numbers cut off for cirrhosis were somewhere between 12 and 17. So I think if you're in that range, you can probably consider the patient has cirrhosis. I mean, these guidelines go down to 11 for hepatitis B, but you know, I think between 11 and 17 is a pretty narrow range. So no matter what disease you have, so I think it's very useful, although it's only approved, of course, for hepatitis B and C.
Thank you. Another question was, I guess, given the fact that you're an author for the guidelines, I think this is something that you could probably touch upon better than anybody. There are a lot of scenario analyses in the AGA guidelines. In particular, for example, low risk of cirrhosis is like around 5% in the particular low risk population versus 30%. Are those reflective of what people may be seeing clinically in their practice, upwards of 30%?
It depends on their clinical situation. I mean, if you're a referral center like we are at Mount Sinai, we're in the 30% range almost all the time. And lots of times, particularly now, since the low-hanging, Hep C fruit has been all treated, a lot of the patients that come in are much sicker than the ones that came in 2 or 3 years ago. Whereas if you're actually out in a big internal medicine practice or a large, HMO somewhere, you're probably talking more like 5%, cirrhosis in the general population with Hep C.
With regards to NASH, which is clearly an emerging topic, so clearly the AGA guidelines gave kind of an initial look into how they would be looking at NASH. What do you think would be the catalyst to have a more definitive recommendation? Is it more data, or is it more of these clinical trials reading out? What do you think would be the catalyst?
Yeah, I think both. Obviously, that's the same question. But I think a lot of the clinical trials have been using FibroScan with a CAP score. The CAP score, which is approved now in the U.S., is a calculation that gives us a quantitative fat measurement. So I think if we were to use that together with the fibrosis score, I'm sure it would be at least as good as, if not better than, the MRE, and way more convenient and way, way cheaper than getting MRIs, actually. So I think it just hasn't had enough time yet for that data to come in. So I know a bunch of the studies have already closed out, actually, and sent their FibroScans back, some of the fatty liver trials.
Maybe it's beyond the scope of the committee that wrote the guidelines, but we've gotten a few questions with regards to ultrasound-based elastography, which were not mentioned. Maybe you could comment on that first, and I have a follow-up question.
Yeah, I mean, that's a new, relatively new technology. I saw the machines at EASL where you could do both VCTE and abdominal ultrasound at the same sitting with the same machine. The thing is, it's not really an office-based technology. It's something that sits in radiology for the most part, in the U.S. anyway. And we wouldn't have control over it, so we'd have to be scheduling those patients out and having the radiologists read both the FibroScan and the ultrasound, and that certainly goes against our grain. Those of us who like to use the machine get the immediate feedback, and of course the patient loves to get the immediate feedback too as to what their numbers are.
So the follow-up, and I think you answered it, but just to make it absolutely clear, there was a question and a comment buried within it that said that there are people out there that are essentially claiming both technologies to be equivalent. And so, is that true or not true?
Both. Which both technologies?
VCTE technology, FibroScan, and ultrasound-based shear wave elastography.
There have been no studies to compare, so I don't think we could say that. There's way more data on VCTE than there is on any of the other modalities so far.
The next question is with regards to the cutoff values that were presented in the AGA guideline, as well as the ones that were briefly shown from the AFTEL publication. The values are slightly different. And so the question was, should we be using one versus the other, or maybe you can explain some of the differences and why they may be different.
Yeah, I mean, the AFTEL study was based on a much smaller population, and I think probably was a much less rigorous, statistical analysis. These guidelines, I can tell you, after weekly conference calls for 2 years, were extremely scientifically rigorous, and the statistics behind them were extraordinarily carefully done. But none of these, none of these values are like commandments. This is not the 12.5 commandment. It's a number that you should use. You should interpret it clinically along with all the other information that you have, including looking at the patient and looking at the other labs and the other imaging studies. So, I think the main point, the main bullet on almost all of these slides, the last bullet says, use this as a general guideline, the kilopascal number, and put it in clinical context along with all the other information that you have to try to make the best clinical decisions you can for the patient.
Oh, thank you for that. We had another question come in just now with regards to the use of VCTE in autoimmune hepatitis patients. Any experience with that? Do these rough values sort of correlate to that population?
Yeah, we use it. There's very little data. I think there's a few trials, looking at it. Obviously, if you get a really high number, the patient has cirrhosis. But and I think in terms of the lower numbers, less than cirrhosis, there's very little data, but it gives you a general idea. Like, once again, in conjunction with all the other information that you have at your beck and call. In general, we don't do the VCTE if the patient has an acute hepatitis, whether it's autoimmune or anything else. If the ALT and the AST are 1,000, then the liver is going to be very stiff, and it's not going to be, the fibrosis is not going to be represented by the number. So we would wait until the liver enzymes came down close to normal and then do the VCTE, no matter what the disease.
So along those lines, another question just came in. Should an elevated ALT be considered in some sort of an algorithm or calculation to maybe correct for or better interpret the KPA? I think you just mentioned a little bit about that, but
yeah, I don't think we really have an absolute number. If the patient's AST and ALT are less than 150 or 200, it probably doesn't make any difference. If they're higher than that, it may make a difference. We don't know for sure. So, like I said, if it's an acute hepatitis with a really big bump in liver enzymes, we tend to wait until things settle down before doing the VCTE.
Okay, another question, and this is, I think you'd be best positioned to answer this question given your experience with the technology, but in morbidly obese patients, can you speak to the accuracy of the FibroScan to detect fibrosis in those patients?
Actually, if you use the XL probe, it works really well. Actually, my PA just went over to the obesity clinic at St. Luke's on Monday, I think it was. Excuse me. And I think she FibroScanned 25 patients in the getting ready for obesity surgery, and she only couldn't get a reading in 1 out of 25. So I think that that's generally what our clinical experience is, particularly with the XL probe. You can usually find a spot on the ribs to get the probe in and get a reading. Just like it's sort of surprising when you do liver biopsies on these really obese folks, you can usually find a spot where there's not a lot of fat over the ribs. Usually the fat is elsewhere in the body, but not like directly over the ribs, over the liver. So we've been much more successful than we originally expected to be.
Sunil, next question.
So we have another question here. is the stiffness score different in a cholestatic disease, say PBC, versus what you see in a kind of a viral hepatitis situation? And can you speak to maybe some of the differences that the biology would play there?
You know, it depends on, and certainly extrahepatic cholestasis, we know it's not very accurate because of the, the swelling and the, and the inflammation in the liver. In the intrahepatic cholestatic diseases, it's the same general numbers approximately. There's some data about people who use it at PBC and PSC. I mean, we use it. We don't know exactly what the numbers mean, but it gives us a general idea of where the patients, stand clinically, in conjunction with all the other data that surrounds, your average liver patient, physical exam, laboratories, and imaging.
Very good, Dr. Dieterich. That concludes the questions coming from the audience. We're close to the end of our time. Did you have any summary statements that you wanted to make to conclude?
Well, I'm really delighted to be able to discuss this today. These are some, I think, very, very carefully written guidelines about how to use VCTE in clinical practice. There's a huge amount of data for Hep C, a pretty good amount of data for Hep B, and then for the screening for esophageal varices, I think that's a very strong number, 19.5 or 20, which is in agreement with AASLD and Bovino 6 guidelines. However, for fatty liver, we still need more work in terms of the role of VCTE and particularly the CAP score in evaluating fatty liver disease, NAFLD, NASH, and ASH. And of course, other data are rolling in about other liver diseases. So overall, I think this was a great discussion. Lots of questions and lots of good discussion about the role of VCTE in clinical practice.
Thank you, Dr. Dieterich, for those very informed comments. We're privileged to have someone from the committee inform us in this level of detail. I would like to remind everyone that this event was recorded. Everyone that participated will receive a follow-up email with a link to the EchoSense North America website, where there will be a recording. We encourage you to access that at any time if you'd like to review any of the points and to share it with colleagues. And on behalf of EchoSense North America, I would like to say thank you for your interest.
Thanks for your help, Jerry.